colleagues, Dr. Babito and Dr. Professor Chen and Dr. Yefei and Gabo. It's my honor to have a speech on the challenges and outcomes of the calcified lesions literature's update in this year PCI associated with the Great Wall International Congress of Cardiology. I'm Dr. Shen from Peking Union Medical College Hospital, Chinese Academy of Medical Science. We all know the vessel calcification is a very, very old phenomenon. In the Egyptian mummies, you can see there's many calcified lesions on the femoral artery, the pelvic artery, on the aorta or the subclavian arteries. So it's a very old phenomenon of the vessel calcification. And to see the update of the new informations of this calcified lesions, I searched the Medline and some medical science for the literatures. And I only found a few randomized control trials and some reviews and some case series studies. And I found some idea of the mechanism of the vessel calcification research, but there's still no magic way to prevent the vessel calcification. There are many new modalities to overcome and to compare all the modalities in the diagnosis, the intravascular imaging, and the treatment devices to during PCI. They got to better outcome. There's still no large number of randomized controlled trials update. In 2005, there's a paper about meta-study. Is a multi-ethnic study of atherosclerosis in 6,814 cases in the age between 45 to 84 years old, no obvious coronary heart disease. They all do the coronary CTA to evaluate the coronary calcium score. You can see this is a man, and there's a woman in another column. The prevalence of coronary calcium in men is between 60 to 70%, less in Chinese patients, more in white patients. And in women, from 41.9 to 44.6 is less than the in male patients. But nowadays, with the increasing of elderly patient or population and the rising prevalence of diabetes mellitus and chronic kidney disease, the complex calcified coronary lesions are becoming more and more commonly encountered in contemporary PCI. Coronary calcium score as demonstrated as a very important factor in the predictor of coronary events. It's published in 2008 in New England Journal of Medicine. The coronary artery calcium score increasing to over 300. The incidence of major coronary events is increased in the following 5 years. We can see the coronary score increased to more than 300, and the incidence of coronary events is increasingly dramatically. For one paper in 2017, it's a state-of-the-art paper about the coronary artery classification from mechanism to molecular imaging. It's very interesting to note to all the plaque information and plaque formation, the initiation and the inflammation. The inflammation is all through the plaque formation and increased the micro calcification and the progression to macro calcification, and all with the inflammation continued and the inflammation factors interact to the vessel wall, and there are many cells become the osteoplastic-like cells and form the severe calcification in the end. And we know some factors can promote the calcification progress, and some factors can inhibit the progress of calcification. For example, the MGP activated and the BMP4 and 2 can stop the calcification progress, and something can promote the calcification progress, induce all this calcium in deposit in the vessel wall, cause the vascular calcification. Unfortunately, there's no clinical accepted therapy to reduce the vascular calcification. Up to now, there's no accepted therapy to reduce it. In 2020, there's a paper published in Atherosclerosis from the Renew Romani group. They pointed at calcium deposition within coronary atherosclerotic lesion, the implication of plaque stability. It's very interesting to note that the unstable plaque may be with speckled micro calcification, and with TICFA in the artery, there's some fragmented calcification and speckled calcification, and with ruptured plaque also have some fragmented calcification. With this micro calcification in the vessel wall, there is prone to have erosion plaque or TICFA or rupture of the plaques. With stable plaques, there may be more diffuse calcification, or the fibrocalcific plaques. In the pathological way, we can see all these calcifications more severe, more diffuse, and they become more stable. And it's included in this table. We can see with very severe calcification, more stable at purple. In purple, in the stable plaques, more stable plaques is there, and a small amount of ruptured or the CTO cases there. With moderate and mild calcification, it's more plaques rupture. We can see with moderate and the mild calcification, there's more ruptured plaques, and stable is less, and some erosion there. But with no calcification, there may be more severe stenosis, or the stable, or some with erosions, and a small part of with rupture. In that artery, the conclusion is called the artery may show severe calcification in one location, while another, or the distal lesion, may show plaque rupture, suggesting the coronary calcification is not an all or nothing phenomenon, but a continuum of disease progression. And there's some small micro punctuate fragmented calcification is a better predictor of unstable plaque. Large calcification, fibrocalcific plaque, or seed calcification is a better predictor of stable plaque. So let's get into the treatment of these calcifications. The patient with calcification lesions maybe get worse result outcome. This paper is published in CCI 2012, January, compared with rotational atherectomy, rota with plus DS, and compared another group as DS. We can see they followed up 1 year, only 116 cases with rota ablation and DS. The total is 1,537 cases. The death and MI rate in the DS no rotation is 90.3, with rotation and plus DS is 8.7. It's more than in the non-calcified lesions, but it's better with rotational atherectomy plus DS. And in paper about the left main severe calcification treated with rotational hysterectomy plus DS, only 40 cases with left main severe calcification not suitable to CABG. One case died during procedure, 2 cases died 24 hours later. 15 cases with IBP support and 10 cases using IVAS. We can see the results. 2-year survival was 71.7, and 2-year response rate was 19.3. 60% efficacy symptoms relieved. In this very special cases reports, it's an acceptable result, but still there are many the recent paper published in 2022 about rotational hysterectomy or a broom-based technique to prepare severe calcified coronal lesions. It's a randomized controlled trial, include 2 randomized trial, prepare calc and ISA calc trials. All the number is only 274. With 200 patients, they got available OCT images after stenting, including the pooled analysis, and compare with rota and modified balloon or super high pressure balloon, 63 cases with 103 and 34 cases. We can see the results. The stenting expansion is more in the rota group. But the finding the extent no significant difference between these 3 groups. The maximum stent eccentricity and super in high pressure balloon better, and the strict success is better in rota group. But in the conclusion, they said in patients with severely calcified lesion undergoing DS implantation, lesion preparation with rota or not balloon or super high pressure balloon was associated with comparable stent expansion. Super higher pressure balloon is associated with less stent eccentricity, whereas strategy success is more frequent with rotational hysterectomy. So I think it's a very difficult condition to design a very good randomized controlled trial because if there are uncrossable calcified lesions, we cannot compare all these devices. So calcified lesion need proper plaque modification. If there are no proper plaque modification, there will be less procedure success, such as suboptimal stent expansion, stent loss, and increased pre-procedure complications, such as flow limiting stent edge dissection, vessel rupture, nerve flow, or something else. And I just feel for clinical and anatomical factors, moderate to severe calcification has been independently associated with increased MACE and long-term rates of ISR, stent thrombosis, TR, or myocardial infarction and death. So let's see the safety and efficacy in the post in trials examining calcium modification techniques. We can see this is the trials with Roxas, prepare calc, orbit with orbital cost with clone orbital, and disrupt trials with IVL. And the number is not too much, 100 or 443 here, and IVL is for the 31. There are some dissections, little with nerve flow, and the perforation rate in the prepare calc trial is 4.4%. And we can see the MACE rate, in hospital MACE rate is not too high, but in the follow-up, the MACE rate is about 20 something. And the IVL trials only followed in 1 month, so it's very little numbers. And we know there are these 4 methods to do devices to do the calcium modification with this rotor, and this is orbital atherectomy, and this is laser, and this is the IVL lithotherapy. And
Dr. Shen, Dr. Shen,
okay.
Sorry for interrupting you. I think only 1 minute, left for you.
Okay, I will very quickly. This is another paper in 2020 called is Breaking the Deck Road of Calcified Coronary Lesions, a contemporary review. In this review, they compared the modified devices differently, and in the imaging of OCT and IOS to calculate the OCT score or IOS score of calcium to define how to choose the devices to modify these lesions. And in the relevant clinical trials, compare the method with cutting balloon or the scoring balloon or the rotational atherectomy and the orbital atherectomy and laser atherectomy and IVL to see the procedural success rate with all these devices is increasing. And rotor tripsy is called a rotor after rotor do the IVL to see the results. As only 43 patients in the real-world multi-center cohort study, and all case success get success in all cases. They do it as a bailout strategy. And in another paper from Romalinda, 2022, compared to temporary management, severe calcified coronary lesion, they also show all these clinical studies, or the outcomes of this device using these different devices. And they got an algorithm, and maybe well presented by Dr. Babito. And a very interesting paper published 2021 has identified the coronary calcification of OCT using deep learning with AI study to show the deep learning can make the coronary calcification properly, efficiently, and accurately identified. And this got to the summary. Calcified lesions still was a problem in coronary artery disease. New knowledge about mechanism and new modalities to identify or overcome these lesions may lead to better outcome, but need trials to confirm. If one device is not sufficient, a combination of devices may achieve the desired outcome. IVL may help in choosing different devices and decide the endpoint before stenting.